Hi everyone, this is Neil Wrighter, consultant audiologist and director of Clearwax. Thank you for joining me in another demonstration video today of our recently developed WAXscope, which is due to be launched very shortly indeed. To register your interest, please feel free to email info@clearwax.co.uk and we can add you to our mailing list. This particular patient attended with medially occluding, dead dry skin plugs, and they have to have this removed every 6 months or so. It not only affects their hearing, but the patient wears bilateral hearing aids, and this dead skin causes their hearing aid to whistle, so they get acoustic feedback, and that's because the sound being amplified into the ear through the hearing aid, it hits this dead skin and it reflects back out of the ear, and that already amplified sound gets re-amplified by the hearing aid, and that cycle continues, and we call that a feedback loop, and you get whistling of the hearing aid. Now, the reason why this patient gets, I feel, this dead skin on a chronic basis is because you'll see once I remove this, about 1/2 centimetre away from the patient's eardrum, the ear canal does narrow quite a lot. Most of our ears do. It's a natural narrowing called an isthmus. And we also have another narrowing in the ear between the first and second bend of the ear canal, which is more towards the entrance in the outer third of the ear canal. But this patient's narrowing is probably a bit more severe than and abnormal, would I say, compared to the normal person. And I suspect that as the skin is dying and shedding off the eardrum, because of this narrowing, it gets trapped, and eventually it forms into a plug. So I've just put some oil in, just trying to loosen this, and then I've gone back in and I'm working from the top part of the ear canal. I'm just peeling it away, and this plug came out in a good big piece actually in the end. Initially, I had to reduce the exposure because of dead skin. Keratin is highly reflective, and as a result, when you go in with the WAXscope or even the iClearScope, the endoscope, you get a lot of reflection. So I just turned down the exposure a little bit. So I've just changed the focus there, you can see, because I want to now start peeling some of this dead skin off the patient's ear canal. So we've removed the major plug, but now we're removing dead skin, and we're not too far away from the eardrum here. We're on the posterior canal wall, and the suction probe just got blocked there. I've just increased the exposure now because it's less keratin, it's a bit less reflection. And you can see the clarity here. We can see the actual texture of the dead skin. I'm just peeling it away. And there is some keratin very deep in the ear canal adjacent to the eardrum, which I'm going to remove. And I'm going to zoom in. So this is the zoom feature that we've been working on. So you can probably see the narrowing of the ear canal. In fact, the ear canal's narrowed so much that you can't visualize the whole eardrum. So I think I'm going to zoom in now. Yeah, there we are. And we're going to just adjust the focus a little. So I'm happy with that. And of course, the zoom really helps because it gives you, although it's a really small piece of dead keratin on the camera, it gives you a big target. And you can see how we can just easily remove that keratin away. So zoom back out. There's flakes of skin here and there. I'm going to remove as much as we can now. I'm just stretching the ear open. There's some dead skin right on the eardrum there, on top of the short process of the hammer bone. It's quite crusted. I managed to get a little bit, but because it's quite crusty, we're going to just let the rest of it migrate. That will naturally migrate. And this patient has to attend every 6 months anyway. So it's not worth trying to remove that last little fleck at the top. Because you're at risk of course, perforating the eardrum when you're working that deep in the ear canal. So if that came away easily, I would have continued, but there was a bit of resistance, as you saw, although we did get some out. This is where the narrowing is, probably just a bit further forwards, just here. And then the ear canal protrudes back out again. So just going to peel some skin away here. And then just a bit at the entrance. Now I'm happy with that. And we're going to visualize the patient's eardrum. I'm going to stretch and straighten the ear canal so we can see more of the hammer bone. In fact, we can see all the hammer bone there. But in order to visualize that, we have to use the speculum to straighten the ear canal. So you're having to, with the speculum, move it to the right, so the tip then angles towards the left to visualize the eardrum. Of course, with an endoscope, that's where an endoscope, it's in a league of its own, because you can direct the endoscope into the ear itself and then move your wrist to visualize the whole eardrum. With the WAXscope and with all other modes of visualization, the lens is actually outside of the ear, it's not an endoscope. So this is the same patient, this is their right side. They were getting some feedback here. So it wasn't as bad as their left ear, but you can see they've got this crusted skin. And we're going to peel this, and we're going to peel it also off their eardrum. So I'm just coming down at the top. It's quite adhesive dead skin. It's really attached to the canal wall, and you can see how we're peeling it away slowly but surely. So the specular size that we're using is internal diameter of 4.25. We've got a smaller size, which is a 3.5 millimeter, and then two larger sizes, a 5 millimeter and a 5.75. This is probably going to be the most common size that we use, the 4.25, or at least I will. But we have got some bigger sizes in case, and also smaller ones for narrow ears, which will definitely come in handy, and I've used those quite a few times. I don't actually think I've used a 5mm yet. I've used it on a couple of patients. The 5.75 was probably surgically operated ears, so people with mastoid cavities have got really large entrances and internal cavities. So I've peeled this skin all the way to the eardrum on the roof. This is just a secondary piece of skin at the floor of the ear. I'm just going to get rid of that. So we're actually, this skin, we've peeled it all the way off the roof of the ear canal, and it's actually on the eardrum, this top section. So I've just adjusted the focus a little bit. You can probably see that in the distance. It's attached right to the top section of the eardrum. Suctioning it, but it's putting up a fight. I think we're going to zoom in a minute. Let's see if memory serves me right. And maybe not. You can see that skin's almost coming away. The near section of it separated. And again, just using the fine end. The fine end is great with dead skin because it limits the possibility of clarinetting. Clarinetting is when the skin violently flaps when you perform suction. So I thought I did zoom in. So here's that part. Just going to adjust the focus a little. And again, it just gives you a bigger target. I'm going to peel that away. I think we managed to. Again, I'm going to adjust the focus because it's a bit deeper now. Go back in. And there we can see the eardrum now. It's just a few hairs just at the entrance. That's slightly obscuring the view, but not enough to affect us. And again, this patient's got a really narrow isthmus. You can see that there. And to visualize that eardrum, I'm really stretching the ear. So I'm going in with the speculum. And this is the, where we're aiming at now. When I put the speculum into the ear, this is the natural angle that you see when you insert the speculum. So, but to visualize the eardrum, we're then having to rotate with the wrist, the WAXscope from left to right. So the tip is moving from the back part of the ear canal towards the front. So you're stretching and straightening the ear canal. So you have to apply some force there. So just dead skin, just under, this is called the anterior inferior canal wall. This is some crusted dead skin. I'm going to gently peel that away. Again, you can just see the great clarity we get, the precision it allows you to perform these procedures. So the patient has got quite a bumpy ear canal. It's possible the patient here has got some benign osteonecrosis. This is a bit of a dip in the ear canal. So again, I'm going in, that's the natural angle, and I have to stretch the back cartilage in order to visualize the front part. You can see the whole eardrum there. I hope you enjoyed that video, guys. And once again, if you are interested in the WAXscope, please do email info@clearwax.co.uk. Thank you, bye.